Hi, my name's Alina, and today Nye, Jasmine, and I will be discussing the malignant neoplasms of the ovaries and the role ultrasound plays in its diagnosis. Ovarian cancer is found in the reproductive organs of women, and it has subtle symptoms, which is indicative of its high mortality rate. This is why early diagnosis is so critical. The three distinct cells of the ovary are the epithelial, which is the cells surrounding the ovary, the stroma, the connective tissue within, and the germ cells, which are the precursor cells that mature into oocytes. Ovarian cancer encompasses a variety of tumors within these cells. For example, dysgerminomas originate from the germ cell, and granulosa cell tumors originate from the stroma. However, 80 to 90% of malignant tumors are found within the epithelial layer. Pelvic ultrasound is the primary modality involved in diagnosis for patients. More specifically, transvaginal ultrasound is particularly useful to closely evaluate the varying characteristics within these masses. It's important as sonographers to distinguish between benign and malignant characteristics, as any masses presenting with malignant features should be further investigated, commonly with biopsy and MRI as directed by the radiologist. This is critical in the overall management for patients, as poor diagnosis of these tumors can lead to invasive surgeries and stress on the patient.
Signs and symptoms of ovarian cancers are consistent with general cancers. They include general malaise, fatigue, pain, constipation or urinary symptoms due to the compression of the lesion against or on the urinary bladder, bloating, abdominal distension or a large abdominal girth caused by ascites or by the size of the lesion itself, and abnormal vaginal bleeding. Patients presenting with these symptoms are often postmenopausal and have late-stage disease, and therefore may also present with metastatic disease, as patients with early-stage carcinomas are often asymptomatic. Most common ovarian cancers are derived from ovarian epithelium, with one very common being cystadenocarcinomas. There are two main types, serous and mucinous. In the diagram here, we can see that these neoplasms are commonly seen in the peripheral portion of the ovary, which is where the epithelial layer is. A common differential diagnosis for this is cystadenomas. The similarities between these two types are that both contain fluid and solid components, which is a strong predictor for malignancy. Both contain singular or multiple irregular papillary projections, which exist as a solid component of the neoplasm. Color Doppler flow is seen within these solid components. Both are strongly infiltrative into surrounding structures and can contain septa with variable thicknesses. These septa may also present with internal vascularity. Both may also have calcifications. The differences are that serous types are more common, bilateral, unilocular, small, and the cystic component of serous types are anechoic, with little to no tonal echoes. On the other hand, mucinous types are less common, unilateral, multilocular, and large, ranging from 6 cm to 50 cm. The cystic component of mucinous types contain low to mid-level echoes due to the presence of mucoid materials, hemorrhagic and cellular debris, which is not seen in serous types. On the left here, we see a transvaginal image of a right ovary with a serous cystadenocarcinoma. We can clearly see the anechoic cystic spaces here, as opposed to the papillary projection here, which is the solid component of the neoplasm. On the right here, we have a transvaginal image of a mucinous cystadenocarcinoma. We can see the papillary projection here and the cystic spaces. Now, the cystic spaces are clearly not anechoic and instead have low to mid-level echoes due to the presence of cellular debris.
Endometrioid carcinoma are malignant epithelial ovarian neoplasms. They are the second most common form of epithelial ovarian malignant neoplasm, and patients are normally diagnosed in their 5th or 6th decade of life. A link has been made between the presence of endometriosis and the development of endometrioid carcinoma. This is important to note, as the appearance of this neoplasm varies depending on its site of origin. For endometrioid carcinomas that originated outside of a pre-existing endometrioma, they are best described as multilocular complex masses with both a cystic and a solid component. They are approximately 10 centimeters in size and predominantly unilateral. Looking at these two images here, you can see these cystic spaces with low-level echoes surrounding the solid component of the mass. You can see that acoustic enhancement, and you can see that the solid component is isoechoic to that surrounding tissue, and you can see that it separates those cystic portions into those multiple locules. For endometrioid carcinomas that have originated from a pre-existing endometrioma, they are best described as unilocular cysts with multiple papillary projections that have internal vascular flow. Looking at these first two images, you can see the predominantly cystic space, which also has low-level echoes, and you can see the isoechoic papillary projection there. The presence of the papillary projections may lead to a differential diagnosis of borderline tumours or clear cell carcinoma. In this last image here, you can see powered Doppler demonstrating internal vascularity in that papillary projection. This is a key indicator of malignancy, as you will see throughout this presentation.
Ovarian clear cell carcinoma is a malignant epithelial neoplasm and accounts for roughly 8.5% of all ovarian cancers. It's correlated with women presenting with endometriosis, as 25 to 58% of women diagnosed with clear cell carcinoma also have this condition. On ultrasound, these can be identified as complex smooth margin cysts. They can present as unilocular solid cysts, multilocular solid cysts, and more rarely as solid cysts. These cysts are mostly discovered unilaterally with low-level echoes and a mean range of 13 to 15 centimeters in diameter. The hyperechoic tumor within these cysts have irregular margins, moderate to high vascularity, and vascularized papillary projections. A differential diagnosis for the clear cell carcinoma includes endometrioid and dysgerminoma, as these characteristics on ultrasound can appear similar. In order to provide the patient with an efficient assessment, the sonographer should be attentive to the surrounding anatomy, extending the scan if needed as to visualize any irregular pathology seen within the pelvis. Malignancies have the ability to metastasize and cause ascites, so by extending the examination, the sonographer is able to investigate thoroughly.
Ovarian cancer is staged using a classification approved by the FIGO Committee on Gynecologic Oncology. Stage 1 refers to a tumour that is confined to one or both ovaries. Stage 2 refers to a tumour that has spread to other pelvic structures. Stage 3 refers to a tumour that has spread outside of the pelvis and/or metastasized to the retroperitoneal lymph nodes. And Stage 4 refers to a tumour that has metastasized outside of the peritoneal cavity to locations such as the lungs. We as sonographers can assist in the final staging by investigating for parenchymal metastases in locations such as the liver and detecting morphological changes in infiltrated lymph nodes. There are three main treatment options for ovarian cancer depending on the stage of the neoplasm and the individual patient. Fertility-sparing conservative treatment can be recommended for younger women and involves a unilateral salpingo-oophorectomy. A primary debulking surgery followed by adjuvant chemotherapy is the treatment method of choice. If optimal reduction was unable to be achieved, then a secondary surgery will be performed post-chemotherapy. For patients that are unable to undergo that primary surgery, neoadjuvant chemotherapy is required.
So to summarize, clinical indications are very vague and non-specific for ovarian carcinoma, and that's why a thorough investigation is necessary for every patient, not only pertaining to the region of interest. The common epithelial neoplasms discussed have characteristics and features that are very similar to each other and are strong predictors for malignancy. And therefore, as sonographers, it is so important to recognize and identify these features to allow for appropriate follow-up and an accurate staging. In doing so, we allow for the best treatment option to be determined, ultimately allowing for the best prognosis and care for the patient.